Good afternoon, everyone. My name is Rebecca Saltzbaugh, and I'm with the Christopher and Dana Reeve Foundation. And I would like to welcome you all to today's webinar on preventative cancer screenings for women living with paralysis. Thank you so much for joining us for a panel discussion on this very important topic. I would like to give a visual description of myself. I am a white woman with brown hair, glasses, and a pink shirt with a white floral pattern. And behind me is a mostly navy background with a little bit of orange, yellow, and red in it. Before we begin, I'd like to cover just a few housekeeping items. We do have closed captioning available. If it's not already appearing on your screen, you can go down to the More button and click on the dots and you will see captions, so make that selection. We will also have an ASL interpreter with us as well. There will be time at the end of the webinar for questions. If you have any questions, please feel free to put them in the Q&A box, and we will get to those again towards the end of our time together. So now I'd like to turn the mic over, so to speak, to our three panelists and ask them to just give a quick introduction of themselves. Dr. Dunbar, I'll start with you.
Hi, thank you for this opportunity. My name is Erin Dunbar. I'm a neuro-oncologist based in Atlanta, Georgia, at the Piedmont Brain Tumor Center. I'm privileged to help take care of patients who have been touched by tumors that either started or spread to the nervous system, the brain, the skull base, the spine, the pelvis, and the nerves. My background is in medical oncology and also palliative and hospice medicine. It is an absolute privilege to be a part of the panel. Thank you.
And did you want to give a visual description?
Thank you. So I have strawberry blonde hair. I'm fair-skinned. I'm Irish American. I am about 5'7" tall. I'm in a turquoise dress, and I'm sitting in my home office today.
Thank you so much. Sherry, would you like to introduce yourself?
Sure, my name is Sherry Davidson. I'm a quadriplegic, a C4, C5. I know they changed the way things are characterized today. So that tells you a little bit about my age, which I'll go to my hair. It's brown shoulder length with some gray in the front from everything I've been through. I'm wearing purplish glasses and a black and pink and white floral shirt with a Reeve background.
Thank you so much, Sherry. Liz, please introduce yourself.
Hey everyone, I'm Liz Prasad. I am Guyanese American. I have brown skin and short black hair with a little gray coming through. I think like Sherry, just everything that has been happening in my life. I'm wearing a pink sweater with black buttons, and my background, there's a beautiful black and white curtain with the sun coming through the window and just some trinkets up on the wall behind me. I have spinal muscular atrophy type 2. I was diagnosed at 9 months. My parents were told I wouldn't live past the age of 2, and I'm 45 years old now. And I look forward just to sharing more about my journey with living with a neuromuscular disability and also living with cancer as well.
Thank you, Liz. So we're going to move into our panel discussion, and I'm going to ask Liz and Sherry to share more of their stories. Sherry, would you like to go first?
Sure. So, like I said, I have a spinal cord injury. I was injured at age 16, and I'm going to fast forward through all the ups and downs of just having a spinal cord injury, where you really have many issues that you face, but they're related to your injury itself. So pressure sores, swelling. I mean, I did have gallbladder, which you could say is quote regular, but most of my complications are a result of things that are corresponding to my disability. So interestingly enough, my connection to Dr. Dunbar is I went down to the Shepherd Center to get 2 pressure sores operated on. Spent longer there than I expected because I developed complications. I left in October and I came home in April. And in June, it was time for my mammogram. I'm 57. but at the time I was 41, and I do it around my birthday. So it was June. And right before that, my attendant was dressing me and felt a lump. And so I went and got the mammogram. There was a lot of whispering, and I heard the word comprehensive, which I thought whispering and a word isn't good. And the next thing I knew, I was having a biopsy. Now, lead up to that, I was getting Depo Provera shots every 3 months from my OBGYN. And when I would go for my shots, he would give me the shot and I would leave. He never asked me if I was doing breast exams or someone was doing them for me. And he never did one when I was there. And in retrospect, all of that is totally wrong. You should have been doing it for me every time. Anyway, luckily I had an attendant who discovered the lump. I did get a call from this OBGYN, who is my OBGYN no longer, on July 7th, telling me 14 years ago, telling me that it was positive for breast cancer. Luckily, very early stages, stage 1. I met with one oncologist, and then I met with a second who was also a surgeon and happened to be a surgeon for me in many other non-breast surgeries. So she was like, "You've got to be kidding me." And I have to say that I couldn't believe that after everything else I had been through, the thing that was the least that crossed my mind was that I would get cancer. No one is immune from cancer. And I think people with chronic disabilities of any type, or when you have a serious disability, you think about the things that go with that disability. Your brain really doesn't go to all the other things, and you really don't want to take the time to do the preventative screening necessary as you age to deal with cancer or to deal with whatever else you should do to make sure you preserve your wellness as you get older. Just getting from day to day is enough. Like one more doctor's appointment or one more issue to deal with is not fun. But prevention is the key to cure. And, I didn't like getting mammograms. They're not comfortable. They are arduous, but it's important because trust me, luckily I didn't have to get chemotherapy. I got a lump. I could not get a lumpectomy because I'm a quadriplegic and I can't feel heat. So I had to decide what to do. And my decision was to get a full mastectomy because I felt that I just don't want to deal with this anymore. And I am not a candidate for reconstruction because as a quadriplegic, I have no extra tissue. I am a bag of bones under here. And luckily, getting breasts, bras with, the little scrunchie that goes in, my boobs were better than ever. But so I had the surgery. My surgeon who knew me calls me her fragile creature. It is not something what I had that you would usually need to stay overnight, but she wanted me to stay overnight to make sure I didn't have any complications, which usually occur at night. And I left the next day. I was offered medication. There was only a 25% chance that I would have a recurrence, and the medication would only reduce that to 12.5%. However, the side effects had a lot to do with bone density and sitting in a chair. I have enough issues with bone density that I decided, no way, I'm not taking meds that are going to make my bone density worse. And I'm lucky that 14 years later, I am still cancer-free. I do a mammogram regularly. I was genetic tested. I'm an Ashkenazi Jew. So I wanted to make sure that my sister and anyone that needed to know in my family, if I was BRCA, that they would know I was not. So, this was just, I don't know, a bad movie, as my friends would call it. The one thing I will say, which many of you may find strange, is that it was a little bit of a liberating experience, because for most of my times of being ill as a quadriplegic, I was so ill that I didn't know what was going on. And other people had to make decisions, and doctors and everyone else was in control of what happened to me. But when it came to cancer, I was in control and I could make the decisions that I wanted. And I felt that very empowering. I think it's different because I had experienced the other side of not being able to control what I wanted. And so I think that that was very important to me. And I did make the decisions that I felt were right for me, and it turned out to be right for me. I'm a huge advocate in many areas. The biggest area is women's health, which, as you well know, includes mammography, pap smears, and any other examination that only women luckily get to get. And a big victory for the new regulations that are out that are requiring accessible mammography machines, exam tables, your individual attendant not having to help you in any way. So there's been some real progress in the last couple weeks on this issue. And I would just end, I'm sure we'll have questions, but I'll end before turning this over to Liz, by saying that this is not something to be ignored. You, as an individual, whatever your disability is, are likely to get breast cancer just like anybody else. 1 in 8 women get breast cancer, and 75% do not have a history in their family. And just because you have a disability does not take you out of that quotient. And there may be instances of treatments we get that we don't know that may create that to be a higher number. So I would encourage you, no matter how much it is another battle on your plate, please, please, please do that preventative screening, because what comes after will be worse. So thank you, and I'll turn it over to Liz, and I'm sure we'll have time for other discussion.
Thanks, Sherry. Really appreciate you sharing your story. So I just wanted to talk a little bit about my journey having spinal muscular atrophy, which is a neuromuscular disability, and also being diagnosed with stage 3B rectal cancer. So as I mentioned before when I introduced myself, that I have spinal muscular atrophy type 2. I was diagnosed at 9 months old, and I'm 45 now. In, I would say, March, April of 2022, I started not feeling well, just really tired. I was also taking the brand new drug for SMA to slow down progression, called Evrysdi. And there was just a lot happening in my life at the time. My father had passed from COVID in 2020. I moved out of my childhood home, living with my parents for 42 years at the time, into a fully accessible home with my husband, which I'm here now and just very happy about that. But there was just a lot happening. And so my husband noticed, he's my full-time caregiver, that when I was going to the bathroom, that there was blood. And that's a big indicator of rectal cancer, colorectal cancer. And obviously very scary. It wasn't just one time, it was multiple times. It was different ways that it would exit my body. And I just wasn't eating. I didn't have an appetite. And so I got set up with a gastroenterologist that year, April, I would say, of that year. Also in 2022, I lost about 30 pounds. That's also another big indicator. And for somebody who isn't big in general, that was a very, very big deal for me and my body and just the changes that I was going through. It was very painful how quickly I lost the weight, and just the fatigue, and just being in bed all the time. It was very difficult for me to get out of bed. I was also finishing up my career at Georgia Tech. I retired December of 2022 after working 21 years with the Tools for Life Assistive Technology program in Georgia. And I actually see majority of my team on today, old members and new members. So I appreciate y'all being on, supporting and everything. Y'all are wonderful and I miss you very much. I was officially diagnosed with rectal cancer June 6th of 2022. This was after going through getting flex scopes is what they call them, where it's basically like colonoscopy. They're going in to look. I had complications from the very beginning due to having spinal muscular atrophy. The very first scope that I got, they were unable to get an IV in my veins. I'm a very difficult stick. That's something that happens a lot with folks with disabilities. We're often dehydrated and they can't get to our veins. So I had to go through my first scope without any sedation. And it was probably one of the most like anxiety-ridden, painful experiences that I've had. It was all women in the room, including my gastro. And I remember they were just saying affirmations and saying, you're a strong warrior, you're a strong woman, you can get through this. And I did. The good thing about not being sedated was I just kind of focused on the camera and actually saw what was happening in my body. So I saw the tumor, I saw when they took the biopsy. I know that sounds a little weird, not everybody can handle it, but it was kind of me just being able to get access to that. And no, if I was sedated, I wouldn't have seen those things except for images after. So I went through that, like I said, came back June 6th. I was diagnosed with rectal cancer stage 2. I ended up having surgery that year, July 11th. The surgery was, it went really well. It was a robotic surgery where they went in and removed the tumor and the tissue around the tumor. They had trouble sedating me because, again, with SMA, my mouth doesn't open very wide. I am always breathing on about 17% room oxygen anyway. I don't have very strong lungs. Again, with neuromuscular disability, being put under sedation is always something that you have to be mindful of and consider. So the surgery went well. The sedation part was very complicated. They kept me overnight. This is a surgery I could have gone home if I was a typical person, but they kept me overnight just to check, just like what Sherry was saying, just to check and make sure I'm okay. And that was primarily for sedation as well. I got the all clear from having stage 2 rectal cancer, September 23rd of 2022. And I was just elated going through all the scopes, going through the conversations and everything. It was a very fast process the first time. Like I said, I just was able to live life, celebrate the holidays with family and friends. I retired from Georgia Tech. My friends threw a beautiful party for me and just was really loving being retired in this house with my husband and just going through life. Celebrated my birthday in January, and March, April of last year, 2023, I just started not feeling well again. Like I was just really depressed, down. My appetite was okay, but just really fatigued, really tired. It's very difficult oftentimes when you have these symptoms every day to kind of know what's happening in your body. You know, is this spinal muscular atrophy? Is this the nature of the beast with my life, or is this something new? Well, we knew it came back because I went to the bathroom and there was blood again. And so obviously I was very scared about that. And just immediately just got very down about it, went back to the doctor to get more scopes and more testing done. I also had an incident in May of last year where I woke up one morning and I was coughing up blood. I get suctioned most mornings and it was just blood coming out. Ben, my husband, rushed me to the ER. This was separate from cancer. It was completely SMA related, but I was diagnosed with bronchiectasis, basically just meaning that the lung issues I have were just now 100 times exasperated. So just having to be even more mindful of breathing and being out with germs and just getting respiratory complications. So as I'm going through cancer, right, SMA is progressing and life is just moving forward, and you've got this extra thing that you've just got to worry about and deal with every day. I was re-diagnosed May 2023 with stage 3B. I will say last year was very slow going. I moved all of my care from Northside Hospital in Atlanta to Emory. The reason why I did that is because my neurologist, who knows about spinal muscular atrophy, and my pulmonologist, who is the best pulmonologist for neuromuscular disability in the entire planet, both practice at Emory. And it was important to me that whoever is dealing with my cancer care, I wanted them to be connected to my neuromuscular disability team as well. And so doing the work to get everything moved over to Emory was a bit of a pickle. Getting records over, it just took a long time and it was very frustrating. I finally got set up with the oncology team after moving from one doctor to the other. My first oncologist, I felt was very dismissive of me. The first time she saw me, her tone was very condescending. She looked at my husband more than she looked at me. She told me I was very cute, which we obviously know, but that's not what I wanted to hear, that day. I just felt like she wasn't treating me like an adult, and that somebody that was capable and intelligent of understanding and communicating. And so I wrote letters about that, and I asked to be switched to a different oncologist because this is way too important to be ignored, right? It's okay to talk to my husband as my caregiver, but talk to us as a team. I'm the primary person. So being switched over took a little bit of time, but I finally got set up with an oncologist that really, I feel like, just respects me, really listens to me, an oncology team. Fast forward to October of last year, after some more scopes, I started radiation and chemotherapy. I did 27 rounds. It was going to the hospital every single day for radiation. It was very difficult. It was very tiring. I took a chemotherapy pill, so I didn't actually do infusion. I was very happy about that because of veins and just dealing with that whole process. When we got to St. Joe's Emory to do radiation, they had a lift ready for me. I was very excited that they were prepared, but the lift didn't work for me. It was very painful for me to actually it was a specialized lift with a special sling. I brought my sling that I use every day from home, but it wasn't compatible, and they wouldn't allow me to bring my own lift into the hospital. So my husband picked me up every single day, would scoop me up, put me on the radiation table, and then take me off and do the whole process of everything. So that was just a lot, obviously, on me, but also on a caregiver as well. I wanted to also mention that shortly after doing radiation and chemo, I had a scan done, and they didn't tell me. Emory has a number of different branches in the Atlanta area, all over the state of Georgia. The particular place that they sent me to get a PET scan, and I didn't know, was in a mobile unit. And it was accessible-ish, but not really. There was a lift to get into it, but think about a mobile unit that's set up with a big medical device like a CT scan table. You could barely move your wheelchair in there. And I have a fairly small adult sized wheelchair, and I kept thinking about my friends that are on ventilators or have bigger chairs. There was no way they would get their chair in there. And so again, Ben had to pick me up and maneuver in that mobile unit to get me on the table. To get me out, he actually just put my wheelchair outside on the sidewalk and just carried me out of the mobile unit and got me dressed. Luckily I had regular clothes on, but what if I was in a hospital gown? Like, you should be able to have your dignity and not be transferred outside while people are waiting in line to get in the mobile unit. I had no privacy or anything like that. So those are the things. And, I've always been a strong advocate my whole life. I remember my dad would always say, your legs may not work, but your mouth and your brain sure do. And you just have to speak up for the things that you need. And having to repeat myself over and over again about my needs or having spinal muscular atrophy and re-explaining was just very fatiguing for me, because I'm scared about having cancer, what's happening to my body. There's not many people out there that are diagnosed specifically with spinal muscular atrophy and cancer. And so my oncology team basically admitted they didn't know what to do with me. I have a very good friend that has SMA, and she is a cancer survivor as well from many years ago. And she's the one that I would go to for talking about like these things, but there just aren't many people out there. I did well with the radiation and chemotherapy. Like I said, 27 rounds, finished November 3rd last year. And I was able to take a break November and December, enjoy the holidays, be with my family and my friends. And while the tumor shrunk significantly, my oncology team, they were really trying to avoid surgery again and just avoid any invasive situations. And so they recommended that I do chemotherapy infusion. So I started that in January, and it was one of the scariest, most painful experiences I've ever had in my life. I didn't eat for 9 days while doing that. I also felt from the day I had chemo in my system at the hospital, I felt very weak. I ended up taking an anti-nausea drug that night, and I couldn't speak because it didn't paralyze me, but it just increased the weakness in my body. My face was drooping and my tongue was basically hanging out of my mouth, and I couldn't communicate with Ben. I was deathly afraid that this was progressing SMA more than anything. And so I was at the junction in my life where I had to really think about quality of life, right? And what 6 rounds of this chemo was going to do to my body later on. There were points just taking the first infusion where I couldn't hold my head up. I couldn't drive my wheelchair. And thinking about, again, what would 6 rounds of that do to me? I thought long and hard. I talked to a lot of wonderful friends, my family, my husband, and I made the decision to not continue with the chemo. And so it was a hard decision, but I feel like it was the right decision for me, especially just dealing with everything and looking at the big picture. I'm very grateful that my oncology team agreed with me and that they didn't fight me on it, and they were very supportive. I was able to wait a little bit, get a scan in March, and the tumor is gone. And so that hard chemo time, just the one infusion, I think really zapped it out of my body. I am now technically considered in remission, and NED, that stands for no evidence of disease. And so I will go back in about 5 months at this point, get another scan. They'll scan me every 6 months to see how I'm doing. I'm still tired a lot. The fatigue is still there. I do feel like there is something with the chemo that absolutely did progress SMA. There are some difficult things I'm dealing with my body changing. I was also told that recovery is 6 to 12 months. And so I just kind of feel like I want to get out there in the world, but I've got to slow down as well too. So I just want to encourage everyone to be a strong advocate for yourself. Speak up, don't be afraid, have a team of people working with you if you can. And everyone out there, whether you have a disability or not, get a colonoscopy. The rise of colorectal cancer is absolutely wild. How many people, especially in their 30s and 40s, are getting diagnosed now? And they're getting diagnosed directly with stage 3 and 4. And so I just highly recommend that everybody go get colonoscopy and talk about poop, because it's important. So
Thank you so very much, Liz, for sharing your story, and you too as well, Sherry. Do either of you have any final thoughts on self-advocacy? Anything else that you wanted to mention about being making sure that you're advocating for yourself?
I just want to talk about, and Rebecca's going to be sending out a list of tips that I've developed that help along the way. And I'll just really, highly sort of go over them, but you really need to be a self-advocate. I can't say that enough to Liz. And from the minute you make that appointment till the finish of the process, and there's things that you can do along the way, which is telling people what kind of disability you have, explaining it to them because they don't necessarily understand, making sure that there's the right people there to help you, understanding what the device is going to be, understanding the treatment, making sure you get names, times, who you spoke to, and write it all down so that you know chapter and verse. And when you go in, and if something isn't the way you've asked it to be, that you can speak to that, whoever's in charge, and tell them what you need. And Rebecca will be handing that out. I will tell you that doing a mammogram, I call it ugly gymnastics. It is awful. It is there, and there's a machine out there called the Giotto machine that was developed in Italy and exists and is in 2 hospitals in the USA, and it comes to you like a dental, he's come to you, so you don't have to, I can't tell you, I have a trach and my arm up, and it's awful, and I joke that I'm lucky I only have 1 boob to do now instead of 2, because it was just terrible maneuvering your chair. And so basically what I really am, and I'm going to advocate till I can't advocate anymore, is that radiological facilities have equipment, and that's what they're serviced on, and when they need a new one, they get the upgraded one, and there's no knowledge or incentive to get something new that's going to be better for anyone. Someone with a rotator cuff injury has trouble with the current machines, and older women are getting cancer, and every wheelchair is different, and I could go on and on. So the bottom line is, speak up also, everyone out there who doesn't have a disability, and those in the medical community whose voices will be listened to more than us, is to say, hey, maybe there's some new equipment out there that's universally designed that'll be better for everyone. So I just want to say, be a self-advocate and create a village. Get your friends who, unfortunately, you find out about, like Liz said, you'd find out about, I didn't know so many people had breast cancer. Well, now they all know about the Giotto machine, and they're all asking. So it takes a village, but don't give up. And you've got to be strong even when you feel like you're weak. And I agree with Liz, if you're not happy with your provider, get rid of them, because there's a lot of them out there, and they should be, you are the director of your care, and you should be treated as such.
Thank you so much, Sherry. Go ahead, Liz.
Yeah. I just wanted to say, self-advocacy can be exhausting, obviously, right? It is conversations every day. It's very repetitive. But for those out there that are dealing with it and that have disabilities, believe in yourself. I am grateful to have the body that I have and to have the life that I have. I definitely know what my purpose is here on earth, just spreading the word about disability and accessibility and just being inclusive. But also just knowing that my disability gave me a leg up in dealing with cancer. The tolerance for pain that I have, again, just talking about my disability, talking about the care that I need. I everyone said to me, gosh, Liz, after radiation and chemo, you look great, right? But I just didn't feel great. And yeah, a lot of that. And it, just again, having a disability, having to communicate with caregivers every day, communicating your care, that does give you a leg up in just helping, yourself and to help other people understand more about you and your care. So I will say again, just disability gives that resilience to deal with cancer.
Well, thank you so much. I'm going to shift gears here and bring in Dr. Dunbar. And Dr. Dunbar, I did want to ask why are cancer screenings so important for women, and in particular those who are living with paralysis?
Absolutely. First of all, I want to say how inspiring those stories were by Liz and Sherry, and I know that that would be reverberated on everyone who's attending this webinar as well. And I want to thank them for their excellent advice. I truly believe that people that have visible disabilities or hidden disabilities, that if we all work together to help overcome some of the barriers that we currently have in current state, we make the entire world better, and we make it better for all of us. So I'm really inspired by Liz and Sherry and all of you guys here and everything that the Christopher and Dana Reeve Foundation is doing. So thank you, both Hannah and Rebecca, for procuring some excellent questions for me. And they were very thought-provoking and very humbling to really be able to try to prepare some wisdom today. What I'd like to describe about cancer screenings is that all of us have a certain, we're all products of our history. We're all mutts. We are all products of our anthology, our race, ethnicity, our background, our exposures. So we all have some unknown risk of certain diseases, and that includes also cancers. And some of us are able to know more about our history by talking with a genetic educator or counselor if we've needed to, or we've known from our storytelling in our family that we might have a higher risk of something. But one of the things that occurs when we have another chronic or major illness is that there are additional reasons that we might really need to have even a higher advocacy for cancer screening. And that's because unintentionally, those other health issues may make it a little bit more likely to have a risk factor that brings on cancer, like obesity. Not your fault. There's no gaslighting, there's no shame. How our bodies are, how much fat content versus muscle. 2 would be lack of mobility or altered mobility. Another would be chronic inflammation or repetitive infections. Another is chronic procedures, surgery, scars, cauteries, repairs, things like that. And then there's also the unintended side effects of the treatment. We've talked about the Prevera shots, the other treatments that people are getting for another chronic or major illness may actually unintendedly raise the risk of certain treatments like hormone therapy, etc. So all of those make it even more important to do cancer screening. There are published guidelines based on age. So the American Pediatrics, American Internal Medicine Societies, all of the specialists have guidelines. But a lot of those are sort of lost a minute when someone has another major medical illness. And so even if you are not well, somebody in your tribe, if they can be really trying to bring back in those continuity doctors in your life to say, hey, wait a second, I also have a prostate and a breast, and there's all the rest of me. Can you be making sure that I'm doing other age-appropriate cancer screening? Is there anything unique about me that might make it more important? And that goes along with even things, I'm just going to throw in, that also goes with vaccinations as well. Again, that's another chronic thing, is routine cancer prevention screening and routine vaccines tend to get lost when people have another major or chronic illness. So Rebecca, I know you had some other questions
Oh,
for me. Would you like me to get ready for the next one?
yes. So how can patients and healthcare providers plan in advance to make sure that needed accommodations are available for a screening? And sort of underneath that umbrella is, what questions should patients and providers ask?
That's a phenomenal question. I would like to take it from a perspective of a clinician. Sherry and Liz talked about finding a therapeutic clinician, patient, and team caregiver relationship. I could not agree more. But I'd like to share with you that when we go into medicine, we have a woefully paucity of training in anything related to disability. We have exposures that are immersion exposures. And if we did not have a family member with a disability or another pathway that took us through being comfortable with someone who might have a physical or a different way that they approach the physical world, not having a loved one or a great exposure to disability, we are fearful. We don't know or understand. So a good example would be maybe if someone comes to me and they are in a wheelchair. Had I not had some of the personal and exposures in my medical training, I would say, gosh, can I get them out of the wheelchair? Does it hurt when I touch them? Am I going to hurt them when I do something? Can they get on that chair? Can I open their legs? Can I move their arm? And so I want just to take for just a minute to say that there's not like a doctor class we take that prepares us for all the incredible types of patients we'll have the privilege of taking care of, or all the diseases and medicines and treatments that we're going to be exposed to or come down the pipeline. So what I want to do is sort of kind of level set a little bit that we're two humans in the room. And so that's a great segue to say, well, how can we think about things from a patient and caregiver's perspective of preparing? And then how can we think about it from a clinician or clinic or hospital perspective? So firstly, my humble thoughts on a patient is it's really helpful for me if people help me prepare ahead. And it might lower the exhaustion factor that Liz and Sherry are talking about. If you portal something electronic, you say, this is the device I'm going to be, riding in on, or this is my disability. Where do I feel? Where do I hurt? What parts move? What parts don't move so well? What things will be hooked up to me? What do I need? Can I get up on a table? What are those things? You sort of tell us ahead of time and tell us your request. I'm going to need 2 physical caregivers. Yes, it's COVID. Yes, there's only one person allowed, but this is what we need. And then we can start preparing for your visit in a very proactive way. We have extra hand on deck. We make sure that we've made as many provisions as we possibly can. So I like that idea of you guys sending us information ahead, and if it's written down and portaled or talked about, and it could be by a caregiver, it could be something written ahead. But I think that that's really important. And it might mean that you need to bring more batteries, more medicines, more food, more supplies, more long chargers, more extra tubing. And that's really important. More Chucks pads, more diapers, more things that maybe our offices don't have. Or maybe we could have gotten it ahead of time because you've let us know. I do like to also say that almost it goes to that sort of humanism together. If give us something to, how can we have a warm, charismatic human exchange? And so sometimes it's like you have something cool on your hat, on your shirt. There's something that we can quickly bond as 2 humans. And I think that there's something really important about that. So sometimes I'm terrified, I'm scared, I feel woefully unprepared to take care of the patient in front of me. And it's like, hey, they got a brave hat on, and hey, they have a shirt that says, autism speaks. I'm like, hey, that gives me something to talk about. And so I do think that there's something about that. And so a lot of times I try to wear something or have something in the room that you can talk to me about. I try and drop something that gives you some fodder to talk to me about. When it comes to preparing for the visit, I also want to introduce the concept of help us connect the dots or fill in the gaps. A lot of times you guys are coming with certain equipment or certain things, but we do not perceive as a single provider or clinic or hospital what is the hole or the gap in between the Medicare bus and all of the different steps that you need us to help partner with you in. And I think that if we can really always talk about the holes or the gaps, I think that is very, very important. One of the things that I want to say that flips into then the doctor, clinic, and hospital perspective is we want to provide provisions and accommodations, but a lot of times we just don't know what it is or how to do it. And we need you guys to help us be able to get those things for you ahead of time. I've asked my patients to write countless letters or put things in satisfaction surveys or dissatisfaction surveys. And I'll say, hey, listen, we're going to do this 3 times. And sure enough, the 4th time, there's been an elevation of resources being provided. Those would be a few things that I would say are some of the initial things that we can do, and start working on a care contract even before we've met. Tell us the things you need. How can we help prepare? And absolutely, if clinicians and clinics and hospitals are not demonstrating that they want to meet your needs, find somebody else, because as you guys said it, you absolutely are the reason that we're all here. You are the consumer, and you absolutely could go somewhere else. And don't be afraid to let them know that and do that.
Terrific. Thank you so much. Anything else that you wanted to mention about during the appointment itself, how a provider and a patient can collaborate together?
So one of the things that I would share with you is, in addition to really trying to cultivate that human bond between all of us, give us clear instructions of how we can really be the best provider for you, right? Just like all of us are introverts or extroverts, or we have a northern or southern way about ourselves, we can negotiate that, and we need to understand. I always say, give me clear instructions, give me clear feedback, what I'm doing, how is it being received. The point that Liz brought up was so beautiful about talk to me, not my caregiver. I'm an adult, it's me, I'm the one in the room. I think that sometimes people slip into that, especially if someone has maybe a difficulty talking, or they are vision impaired. You tend to go to the person who is a little bit easier talking, or can look at my eyes or look at my mouth. But it's that sense of redirecting. I want to make sure that you guys feel very empowered to tell us what we're doing well and what we're not doing well, and how we can best help you. So as we're preparing for the beginning part of the visit, I would say what I would really like to do is say, can you get these things in writing, or can we record you? Can you distill down the action items? What do you, as a team unit, a patient and caregiver team, what are your action items, homework assignments, or takeaways? And what are the things that I'm promising that I'm going to do? What are my action items? So that just like we prepared for the visit, and we're very honest in it in terms of exchanging, we want to make sure we're ending the visit very well. And then we're going to say, and then when are we going to get back with each other? What are our next steps? So that we have concrete next steps. I feel like a lot of times visits are not nearly as fruitful as they could be, because we didn't power through that last critical step, is who's doing what, and when are we next going to check in if it actualized or it didn't, and what's our next touch point. So those would be definitely some points that I would share with you, are things that I think are very, very important. Hold your doctors accountable to making the healthcare system work for you, including multidisciplinary. I could not agree with you more. There is no more deserved person than each of you to have a multidisciplinary team that works for you. I don't want you carrying around CD-ROMs and telling doctors different things and updating other people. We should be communicating and distilling things for you. So that is a key message and expectation you should tell your healthcare team. I'm expecting that you guys are going to communicate on my behalf. You have a team meeting. You have collective wisdom. You guys talk amongst yourselves and distill what the team plan is. And you tell me, because I'm busy living and my caregiver is busy living, and I need you to work for me. And if you don't get that, then find a different team. But there are forums that we can electronically communicate and dial down your crazy, dial down your time of thinking about healthcare, dial down your copays, and all of your need to actually do healthcare. We should be working for you.
Terrific. Thank you so much, Dr. Dunbar. I am now going to open up the floor for questions and take a few of those.
Rebecca,
Yes.
Rebecca, can I say one more thing? I wasn't sure
Sure.
if we were going to touch on any other. I want to bring up an important point that might be a great segue to question and answer, is that at the National Institute of Health and the FDA and all of our governing bodies, patient-reported outcomes, patient endpoints, patient satisfaction, and patient safety are huge reasons we get funded, things approved, and conducted. So not just American Disability Act, not just civil rights, not just diversity, inclusion, access to care. Think medically how important patient-reported outcomes, satisfaction, safety, and quality of life endpoints are. Your voice is becoming incredibly important for the expansion and funding of medical care. So I just want to broaden, before we go into questions, that is a whole distinct way that you guys can magnify and put forward your voices.
Thank you so much for that.
Yeah, the NIH recently designated those with disabilities as an underrepresented group. And I think that's going to make a huge difference in the funding that goes out to not just study things, but I think, Dr. Dunbar, you'd know better than me. I think it's going to also flip to the outcome part because it's looking at
Absolutely. Yeah, absolutely. So I think, you know, back in the 90s, it was a little bit more about getting off of this absolutely asinine backward idea, you know, that everyone was one size fits all, and it included like one physical, you know, wellness. Then it became more about access and inclusion and really having, and that's great. But the next level is about reported outcomes and special individualized treatments for all the unique people, all the unique medical issues, and all the unique goals that are out there. And so really plug into those aspects of your healthcare, because you can't get funding, and drug companies and governments, clinical trials, regular medicines and treatments can't move forward without your voice.
Thank you so much. So I'm just gonna, we'll be able to answer a few questions here. Someone wanted to know, was wondering about the differences between Cologuard and having a colonoscopy.
That's a great question. So there are Cologuard, which is a test looking at small particles of shedded cells that may or may not have a signal of those shedded cells are diseased. There's also looking at sort of blood, looking at cellular breakdown products of what might be tumor cells. And it may not give up in that sample that you do have colon cancer, okay? So it is a test that, if positive, does lead to direction, but it may not have enough ability to detect it based on just the sample that's gotten. There is virtual colonoscopies by CAT scan, but those are also fraught with more false negatives. A colonoscopy is a small camera that is inserted into the anus, into the rectum, and through the into the colon, that visibly inspects using high camera technology, looking for abnormal spots and often doing samples. For someone who can receive sedation, they get conscious sedation. I know in Liz's warrior case, she was unable to, but for the majority of us, we get sedation. The gold standard is to get a colonoscopy. I will share with you that they've never been safer, never been more, sort of comfortable for the average person. I would highly encourage people to get a full colonoscopy if you can.
Okay, and then just we'll have time for one more question. One of our audience members would like to know, is there any new equipment for mammograms?
Unfortunately,
That is a, yeah, please.
oh, you want that? Want to take that?
No, please. You.
It's basically mammogram machines now need to go up and down. My experience in large mammogram centers, that's what they have. So that's pretty much what you've got. If you are going to a mammo van, you need to make sure it has a lift. If it does not, it violates the Americans with Disabilities Act. So if you live in a rural area and you're going to a clinic where there's not a machine that goes up and down, or if there is a mammo van that doesn't have a lift, you should file a complaint with the Department of Justice and the Office of Civil Rights at HHS. As far as brand new equipment, it's not brand new really, this Giotto machine that I spoke about, but it is in 2 places in the United States. And they're places you wouldn't expect, West Virginia and Colorado. It's surprising to me how many medical places don't have them. I think it's it's in price. I don't know how facilities operate with their contracts and everything, but it's probably out of my pay grade. I'll just advocate for it.
So, Sherry, I'll add to that the American Academy of Radiology and also the Susan G. Komen might be able to help people find, so the radiology facilities and the societies and Susan G. Komen. I want people to get care as close to home as they possibly can, but when it comes to a diagnosis of comprehensive care for someone with special other health issues, sometimes a multidisciplinary center of excellence or a major large hospital, particularly ones that have like Parkinson's and stroke, other neurologic disorders, they may have a much higher and robust amount of resources for diagnosis and for imaging. And then when the plan comes together, that plan can be conducted as close to home as the person lives. But a lot of times the diagnosis may need to be done at a major center where they have the most robust minds and equipment.
Thank you so much. And so we're at the end of our time together today. I just want to give a very heartfelt thank you to Sherry, to Liz, and to Dr. Dunbar. I so appreciate all of you participating in this webinar. Truly do appreciate it very much. I also wanted to let our audience know that a recording of this webinar will be available on the Reeve Foundation's YouTube channel. We will be sending a link to that recording to all of you via email. We're also going to include in that email Sherry's fantastic tip tip sheet about mammograms, as well as a resource list that will give you resources regarding accessible healthcare, not just from the National Paralysis Resource Center. We've got a lot of great information that we offer here through the Resource Center. We've got some other resources that we found in other external organizations as well. So I just want to thank you all again for joining us today. And please take our survey that will pop up when you leave. We really, really, really value your feedback. And we use that to look at the content and the format that we'll be presenting in the future. So thank you so much.
Thanks for coming, everybody.
Thank you.